task force. Bonnie and Krista and I would like to welcome all of you and wish you a wonderful summer. It's now summer as of 8:57 a.m. And we'd like to remind you about our event on Sunday at Bear Creek Park at 8 a.m. for the Survivor Celebration. So please join us as you're able. And without further ado, I'm going to introduce the University of Colorado UC Health Palliative Care team. Dr. Jeannie Youngworth is going to be the moderator, leader, facilitator of today's meeting, and we appreciate hearing from the four of you. Please introduce yourself and take it away.
Thanks for that introduction, Carlin. We are the palliative team here at UCH in the inpatient side, and we're going to be talking about our interdisciplinary team approach to the work that we do. And we'll be using a patient's story through a cancer journey. All of the identifiers have been removed for the sake of the patient's dignity and anonymity. But my name is Andy Wood. I am a chaplain with the palliative inpatient team here.
I'll go next. I'm Rocco. I'm a nurse practitioner on the palliative care team and former oncology nurse and also a survivor.
And I'm Megan Prescott. I'm a palliative care social worker with the team. It's nice to be here.
And I'm Jeannie Youngworth. As Carlin said, I'm a physician, a palliative care physician on the team and the director of the palliative care service at the University of Colorado Hospital. We really appreciate the opportunity to be here with you all.
A couple of objectives that we have for our presentation today. The first is to define palliative care. The second is to explore the interdisciplinary team approach that we utilize. And then also to discuss collaboration with the oncology team and with others.
So we'd first like to share a story about a patient of ours. And this patient is Sam. And Sam was a woman who was in her later 30s when she was, I'd say pretty suddenly diagnosed with advanced colon cancer. And Sam was one of the smartest people that I've met. She was in environmental law. She did the fast track through schooling with honors and was passionate about her work and her job. And she was passionate about life. She had that mantra of work hard, play hard. And when she wasn't working, which was a lot, she was outdoors in the mountains, enjoying them, whether it was hiking, mountain biking, skiing. And Sam's world changed with her diagnosis that she presented with severe abdominal pain. And her pain was extreme. It was severe throughout the majority of her illness experience. And it was something that was really hard for her to wrap her head around. And it was hard for the medical team to wrap their heads around also. And we were brought in to be part of the team with Sam during one of her many hospitalizations that she had for acute pain crisis. For a moment, I'm just going to transition to give a little bit of a story behind this collaboration between oncology and palliative care. And first recognize and give a kudos to NCCN, which is the National Comprehensive Cancer Network, who was originally developed, I would say, to create standards of care to ensure delivery of high quality of care for people that are living with cancer. And the reason why I'm calling this out is because back in 2001, they developed palliative care guidelines. And this was, 2001 was before palliative care was even mainstream. So this was very progressive, very forward thinking. And it was about a decade later when there was a landmark study that came out of the New England Journal of Medicine. And the New England Journal of Medicine is, I'd say, the most reputable medical journal out there. And this study put a highlight on that collaboration between oncology and palliative care, and really emphasized that when palliative care is brought early into the care for people that are living with cancer, shortly after diagnosis of advanced cancer, that people did better. Outcomes were better, their quality of life was better, and people tended to live longer. Then shortly after that, the Institute of Medicine, also known now as the National Academies of Medicine, who are advisors to the federal government, they released a manuscript after doing an evaluation of cancer care in the United States. And they named out some gaps in cancer care and concluded that cancer care is often not patient-centered, and many patients don't receive palliative care. Then a few years after that, ASCO, or the American Society of Clinical Oncology, they brought together standards of care, of cancer care for cancer, that included palliative care. And this was now bringing palliative care formally as that standard into the care of patients upfront, upstream, early in the course of the disease, and right around that time, within weeks or short months of diagnosis of advanced cancer. And the expectation now is that you should be incorporating palliative care early on into a person's cancer care. Otherwise, you're not receiving the highest quality of care. And I wanted to make sure that, or actually I wanted to show you some of my favorite adverts, I should say, that show this collaboration and that highlight this. And these adverts are from the American Cancer Society and the Cancer Action Network. And the messaging here is that treating the person in addition to treating the cancer is key in giving people the highest quality of care. And that is done by incorporating, again, palliative care into that person's journey, with palliative care being that specialized medical care that focuses on improving quality of life for people that are living with serious illness, such as cancer, and doing that by helping to relieve and manage symptoms and stress that come along with the serious illness, including the side effects of cancer treatment, and then matching options to a person's values and what matters most to them. And this was seen as a big shift for healthcare delivery. And it was something that we could do now because we had a good body of evidence that this works. And we had the endorsement with ASCO in addition. So when you look at these pictures, I think it really focuses on, we are treating individuals. And there's a story behind everybody. And in palliative care, that's what we focus on, is that story. And it's anybody that's ever been in a consult with us or a family meeting, we spend the majority of our time learning who this person is, their story, even before a person was diagnosed with cancer. And from their story, we pull out themes, we pull out threads that are tying their story together. And those are what we call the value-based goals of care. And what we learned from Sam, from her story, was that her value-based goals of care were, one, to control pain. And this was so that she could do the things that she wanted to do most, as opposed to having to focus on pain constantly and not being in and out of the hospital constantly for this. Second was to continue working. Work is something she was passionate about. This was her identity. This is something that helped her to feel like she was contributing to society, which was very important for her. And then third was being with her partner. They'd been together since high school. They were basically high school sweethearts.
So I think what I'd like to do is take the goals that Jeannie has mentioned, that Sam had, and really deepen the story and highlight the psychosocial assessment as part of the team process. which covers so many things in the setting of a serious illness, and kind of draw the parallels between the palliative care team and social work principles. So many things come up when we're thinking about what we want to lift, trying to identify the individual who's going through the illness. It starts with really basic things like personality and core values and beliefs, coping strategies that have been developed through a person's life, both effective and maladaptive, the strengths that they carry, the vulnerabilities that they have, their interests, their sources of joy, of course, their lived experience and their previous losses or traumas, their mental health, and even their stage of development. And that's just to name a few. And it really is a lot to filter through, to lift up what's most important for the person who's going through the illness. So for Sam, we were able to get to some of the key things that were really central to her identity as a person and as part of a family and a community. And I think to try to simplify things, we apply a few questions and frameworks to try to help take that whole person story and get to what's most important. I'm going to hit the next slide for me, Jeannie. As Jeannie mentioned, the number one thing about Sam was her intelligence. She truly was a thinker. She was an attorney, and her focus was on the environment and on conservation. And as we got to know her, we realized that what this really represented was her strengths and her interests and her joys. Her parents told us so many stories about her fascination with the natural world in childhood and the things that just lit her up. And as we talked to her partner, he told us about the time that they spent together, exploring, hiking, biking, skiing. It was always in the outdoors and always with their dogs. Physicality was a part of how she coped with the stresses of her job. And she loved a challenge, both intellectual and physical. We learned a little bit about her community, which, as Jeannie said, the center of that was her partner and her dogs, and that there were these social circles that were also a part of her life, both her outdoorsy friends that went on adventures with her and her husband, and at work in her professional community. So I think the other framework that we are always thinking about when we're learning about a person is social determinants of health. And that includes things like education, access to healthcare, health itself, economic stability, the built environment, and the social and the community context. And all of this came into play for Sam in ways that we might not have expected, and in ways that might not have been so obvious. But from the beginning, her career remained her foundation and her social connection. And I touched a little bit on the idea of a stage of development being a part of what we are assessing for. For Sam, she was in her later 30s when her illness came into her life. And prior to that, she's a young woman. She's vital, she's fit, as were her friends. Both her and her husband were in a stage of their life where they were really coming into their own identity in personal and professional ways, and as a couple. And with her friend group, they connected through physical activity. They connected through outdoorsy things. And she was an intellectual woman and a physical woman. So she didn't really connect to her friends so much in emotional ways. It was more that outdoor joy that they experienced together. So one of the things that she noticed was that those connections started to fade during her illness, that her friends didn't know how to adapt and how to be there for her. And those contacts became fewer and more rare. And while work was always the most important thing for her to maintain, it became even more important, if that were possible, to be both that intellectual outlet, to replace the physical outlet that she had lost, and to maintain some sense of community outside the relationship that she had with her husband and with her parents. So the relationship with her husband had to adapt as well. She maintained her work commitment, perhaps far longer than I might have thought possible. It was all the intellectual side of things. When her body wasn't feeling well, she adapted to getting to work, and her partner's role adapted. He was driving her to work to make sure that she could get there safely. And so that she could maintain her focus on her work, he took over managing the medical information, researching, understanding, and making sure that they had all the information that they needed to navigate her healthcare. So she didn't have to bog down her mind with those things. He also took on the role of understanding how they were going to manage the change in finances and maintain healthcare insurance through everything that they were going through. As Jeannie mentioned, her mantra was work hard and play hard. And her coping had to change as she lost her ability to use physical activity as an outlet. And I learned a lot about how her emotional side worked when we got to know her in the hospital. She was very stoic. I didn't see a lot of expressed emotion from her. And I remember her explaining the moral distress of her work was something that she was able to do and manage because of her psychological makeup. Her intellect was truly her strength. And she worked with the thing that she loved most, which was nature. But her work forced her to encounter the environmental destructions that were going on in the world. She was able to manage that because her intellect led the way. And her emotional side was really not how she dealt with the world. So we didn't see a lot of emotion for her. And that lifted something that I had to focus on, which was my own expectations, that I would see more tears from her than I did, which wasn't the reality. And also her focus on continuing to work far longer than I would have thought possible. So we were learning about Sam and trying to match her as a team and find ways to empower her throughout the entirety of her journey. One of the things that we also noticed as we took care of Sam, as Jeannie mentioned, she came in with a pain crisis. And through all of this, getting to know her and trying to establish some strategies to help her through this pain crisis, her pain wasn't really improving. In fact, at times, it felt like it might have even been getting worse.
One more slide forward, Jeannie. Thank you. This is a Captain Obvious statement, right? That for most of us, the hospital is a very normal place. It's our workplace. It's where we show up every day and we know how to navigate the halls, usually. We know how to navigate the relationships, the systems, the ecosystem, sometimes the politics. There's so many ins and outs. But for our patients, for most of our patients, this is a very strange place. It's a very weird place. It's a place that they don't want to be because it usually is signaling there's something significant happening in their lives and in their bodies. And this amount of disequilibrium is the work. One of the things that a chaplain will step into. The work of a chaplain is to assess these three different areas: hope, support, and meaning. Whenever we think about hope, we're thinking about a vision for the future that incorporates these current realities that we're facing in the hospital. Support are the systems and people, groups of people sometimes that bring strength to a person, that give them the energy and the strength to move on. And the meaning is essentially making sense of these new realities. All of these are angling toward a type of, I don't know, they interact so that they can help a person make sense with their life. They're integrating. Whenever any of these three things are missing in a person, and I'm sure that many of you guys have seen this before, if hope is missing, if they don't have a vision for the future, if they don't have support systems, or if they don't have the ability to make sense of what they're walking through, That's whenever the total pain increases. Another word that we use is existential distress. The lack of any one of these things is can increase the total pain for a person and impact their ability to respond to what we're going through. And so a chaplain will work on assessing these things with the aim of an intervention. And an intervention for a chaplain is never to try to create these things for a patient. It's to help navigate and access those things in their own person, to help them, to remind them of where they find support, hope, and meaning in the middle of their lives. And so the work of a chaplain is to basically ask questions, to explore, to help them, because in the middle of all the disequilibrium that a patient and their family is experiencing in the hospital, it is so common, and some of you probably have experienced this, that whenever we're walking through a crisis, it's easy to forget where we find these things in our life, forget how we make sense, forget how we find hope, and forget how we find strength in the middle of this. And so it's really a memory issue, and part of the work of a chaplain, I like to say, is helping remind people where those things are for them. And it's never about where the chaplain finds those things. We are very much storied people, so are our patients, and that's why the story is so important. And so we want them to be able to integrate these new realities that they're dealing with into their lives so that they can continue on, hopefully after their hospitalization. And so sometimes we talk about spirituality with a big S, right? That we find in religious traditions. Sometimes we're talking about spirituality with a small s that is not necessarily ground in any type of tradition. And sometimes people say that they aren't even spiritual at all. I think a broader category to think about these things are these frameworks, these broader frameworks that people use in their own lives to find this hope, meaning, and support. It might not be attached to a spirituality at all. And so a chaplain is engaging in all of these different things to try to help them to access their framework. With Sam, you can hear the hope side, the tension for hope with her, and thinking about how is she going to continue to work with this illness, with this cancer. The support tension is around her friends and family that are having a hard time coming alongside her in a way and making sense of this. And so her support was falling away a little bit in the middle of this, creating a crisis for her. And in the ways that she and her partner processed meaning making in the middle of this, how they were making sense of things. All three of these things were very, very present with Sam in the middle of this. And through the work of our chaplains, we were able to engage her processing those things. And we saw improvement in the middle of her total pain, just from the simple yet not simplistic act of engaging in hope, support, and meaning in her life.
I just want to ask Andy if he remembers what Sam said when we asked her what she worried about. Do you remember that moment, Andy? I think it was eye-opening for us. We often ask our patients what they worry about, to open into this space that Andy's talking about. And she thought for a second, and her answer was water pollution, extinction, global warming. It wasn't the answer we expected, but we realized just how deeply we were working with a young woman with a purpose-driven life. It was extraordinary.
As Andy said, there's often a lot going on under the surface. And as we, approach symptom management with our patients, it's a multifaceted approach, an interdisciplinary approach. It's often compounded by spiritual distress, and sometimes it's psychosocial stressors, and often it's a combination of things. So I really lean on my team members when we're kind of getting to the the part of the console when we're trying to figure out symptom management. I can go to the next slide. Thank you. For me as a nurse, I'm diving into what does their pain feel like in their body? Pulling in their disease process from, understanding of those processes, pulling in their values and their preferences, the type of care they'd like to receive. So it's a comprehensive intervention. And, I collaborate with my teams closely with that. It's an ongoing assessment, and ongoing assessments give the opportunity for touch, for interactions with my patients. So I tend to try to build on those little interactions. Reviewing her medications, we realized that her pill burden was a big issue. There was all kinds of modalities for pain management. And so step one was converting this to something easier, something more aligned with her. And, it's not a quick solution. We often have to trial things and make adjustments. So it's often close coordination with their oncologist and their primary care teams. And sometimes their generalist. I think we often back up, take a few steps back and say, hey, let's think about this picture more holistically than just pharmacological interventions, right? And so do things like PT, OT involvement. We have a great, integrative medicine program here, outpatient. I wish they were inpatient, with massage and acupuncture, those types of things. Other things I'm thinking of, can we target the issue? Can we consult intervention pain management for maybe a block if someone has like pancreatic cancer? My radiation oncology teams, if somebody has something we can focus, with tumor burden. And then infections cause a lot of discomfort. So making sure that we're managing these infections correctly. Sam, her most with Sam was to align with pain management, right? That was one of her top goals. And so getting good system management for her was a big win. And another thing was like little interventions. So, sometimes we can have volunteers come by, sit with our patients, pet therapy. We also have an awesome music therapist program here. And some patients benefit from those things. Sam, not so much. She preferred to focus on management of her symptoms with her pain management, with medications. And then also, I think the big win is like getting her outside and like trying to connect her with nature as much as we could between infusions, between those times of being tethered to the pump, right? Often as a nurse, I'm kind of the compass, the interpreter of the hospital system, because as Andy said, we're kind of used to this day-to-day flow in the hospital, and nurses we're bedside, so we get what the patients often go through, and it's an alien environment to them. So I feel like these little actions of just building rapport and trust with them, often learning their preferences, just little things like for Sam, like knocking on her door and saying who you were before you came in, and giving her the opportunity and the autonomy to say, yes, it's a good time, or no, can you come back in 15 minutes? So ensuring that she has that autonomy and giving her that, allowing her to do those things. In addition, she was someone that didn't like agendas. And so when I would talk with the nurses, say, when you go into the room, don't say, hey, here's your morning meds, we're doing them like this. Give her an opportunity to say, hey, well, I'm going to do your morning meds. Would you like to do them now, or should I come back at 10 o'clock? Just those little wins. Another key tenet of nursing I often lean on is veracity and truth telling. We often are faced with patients looking to us after they give horrible updates or they're confusing updates, and they don't want to ask questions. So they turn to the nurses to get more clarity. And my job in these situations as a palliative care nurse practitioner is often pulling back to the big picture, filling in the gaps of trying to look at the forest and not the trees, right? And again, these methods, I'd use these to build rapport, and then it often leads to those harder meetings being a little less tough. Having that trust built makes those hard conversations easier. So this next slide, really focusing on communication. I think as a palliative care team, there's a lot of nonverbal communication that we have. Sam was a tough cookie. She's not someone that showed much emotion. However, her family, spending time with them, sitting, they opened up. One of our greatest interventions that we have as palliative care providers is a non-rushed intervention. And I think our visits are interventions, right? Just the time we spend with our patients to get their story, to bear witness to their tragedy is rapport building. Sometimes a knee-jerk reaction when we have patients starting to tear up, starting to show emotion is like, whoa, here's a box of tissues. And really that's like in our mind, we hear that saying, shh, like, don't cry, don't show emotion, stop that, and shutting them down. And so that's the graphic there, just saying, like, if you do have those times when someone's showing emotion, don't be quick to give tissues. If somebody, it kind of goes two ways, like somebody will eventually say, there's some tissues, or they'll sit there and just be in that moment with you. One good question I love, Megan, I heard you say this the other day, is if those tears could talk, what would they say? And often leads to valuable information. One of the pearls I always pass on to all my nursing people I precept is to commit to sit. Studies have shown, multiple studies have shown that when a provider or someone's in a room with a patient and they're in there for 5 minutes standing versus 5 minutes sitting, the perceptions that the patients have are that person was a better communicator. They understood, they were more thoughtful in their presentation, and they spent way more time with me when really it was the same. And so it's commit to sit. I always tell everyone that. It's a great intervention.
I love what Corey just included in the chat about allowing a moment for silence. It is often in the space of silence that the conversation goes one step deeper. And so many people are not comfortable with silence. It just feels awkward. And if you have a patient or a family who doesn't like it, they'll tell you. But other people really appreciate the space from the thoughts that are right at the surface to allow you to go one step deeper. And Rocco, I'm going to remind you of one thing that I remember you doing really well with Sam when we tried different medications to control her pain, made her mind foggy and fuzzy. And she didn't like that feeling at all because she really needed to protect her intellectual prowess, as I learned to call it. And you did a lot of education with her about what to expect from those medications and some of the side effects that might change with time. And I think she really appreciated the time that you spent with her talking through those things and listening to what she needed alongside of her pain management.
Yeah, and also to build on that moment of silence is an important time because sometimes there really are no answers. There's nothing to say. And just the act of being in the presence of somebody else walking through something so challenging is incredibly dignifying because it can be embarrassing dealing with what you're dealing with, expressing those emotions, and just sitting in silence, knowing that, hey, I'm not ashamed of this. I can be here with you in this. It's so important. And it's hard to do sometimes, right? Our days are so busy. To sit down and just to sit there with somebody can be challenging, but it's so important. We all have our areas of specialty that we work in. And on our team, on the palliative team, we like to distinguish the difference between generalists and specialists just within our different disciplines. We are expected to be specialists in our different areas. For me in spiritual care as a chaplain, for our medical providers in the medical field, for our social workers in their disciplines. But we also have a high expectation for each other to be a generalist in ours. I expect Jeannie to ask questions around the spiritual side of a person. Megan expects me to ask some questions around their social support structures. And sometimes I'll even ask questions around the medicines. Sometimes a chaplain will lead a conversation on code status, because it can be a little bit softer coming from somebody who is throwing out less medical jargon, right? One of the things as a spiritual care specialist that my team knows that I expect from them is I'd like them to ask the initial question on, do you have any type of spirituality, or where do you find strength? As you know, Megan reminded me yesterday, it is, I don't remember a time whenever a social worker has asked the question of, do you have any type of spirituality that supports you in this time? I don't remember a time when somebody said, you know, I don't go to church as often as I should. That is typically whenever a chaplain asks the question, it's usually there's just baggage whenever a chaplain asks that question initially. They might say, you know, I don't pray as often as I should, or there's some type of guilt or something like that. But whenever somebody who is a non-chaplain asks that question, it opens things up way wider than it would if I were to ask that questions. And then I'll follow it up with more probing assessment type questions that kind of help drill down into that a little bit further to understand how those things are important to them. So, you know, sitting before you now is as a spiritual care specialist and 3 spiritual care generalists.
And Andy, I would say that there's many times when we're in a family meeting that the patient and their loved ones really can't wrap their head around the medical things we're talking about until you're the one that's actually describing it. So I think having that overlap in the different disciplines that we have on our team is so important to be able to communicate the best that we can with our patients and their loved ones. And I'd say that this foundation of our team it's an interdisciplinary team. And it's based on 4 core disciplines. And these are defined by the National Consensus Project and the National Quality Forum, with those being chaplain and physician, RN, which I extend to advanced practice provider, and social work. It's always wonderful when we can add additional disciplines on top of that, but these are the 4 core ones. And a really good analogy is what you see here as the hand. This is where our team members, or the fingers, have specific expertise, and each discipline or the fingers have different abilities and different functions, and they're interdependent upon each other. Those interactions, they have to work closely together, and their function and role will often overlap. There has to be a constant communication for that hand to be working together and to have its greatest dexterity. And that comes when the fingers are working together as one. I always say that when we're in a room together, even we've got maybe 4 of our team members there from different disciplines, we're speaking as one person. And this is so that we can achieve more than any one discipline or finger can alone. That's where that strength of our team or the strength of the hand comes from. And then some people might say, well, the palm of the hand also is representing the patient and their loved ones. So it's this interdisciplinary teamwork, this close communication and collaboration that we bring and we integrate with the oncology team. And this is what improves outcomes. So we followed Sam as part of her care team. And Sam had a lot of hospitalizations, a lot of complications. And she was not responsive to cancer treatments. In years after we first met Sam, that's kind of around, I would say here, I'm not sure if you could see my pointer, but over here in her cancer trajectory, where that dotted line becomes the solid line, where one day she had a fall, and she fell when she was in her bathroom and she broke her hip. It was a pathologic fracture from her cancer going into her bone and weakening it. And now she was faced with some really complex decision making. And in the hospital, she had a lot of different options that were offered. The surgeon saw her, talked about surgical repair. And in discussion with the surgeon team, they said, you know, any kind of surgery was not going to be easy because of the way that her cancer in her bone had spread really quite extensively. And that they were anticipating that Sam would not walk again, that her recovery, if she had surgery, is going to be a very prolonged one, it would involve a prolonged hospital stay and followed by rehabilitation in a facility. And when oncology talked with her and us, they said that she didn't qualify any further for that trial or that study trial that Sam was trying to get into so badly. And this was a huge blow to Sam, and she felt really lost and not sure what to do for those next steps. So we went back to the basics that we always do, which is focusing back on what are her value-based goals of care. And this is what guides us. What are the options that she has that are best going to match what's most important to her, and then use that to guide the next steps. So for Sam, number one, controlling her pain. We were actually fortunate at that time that we had transitioned her to a PCA or a pain pump, and we were able to get good control of her pain. And the surgeons didn't think that the surgery was going to add to that, and that what we had achieved was something good and something that Sam was able to, as she would say, tolerate. Second was for Sam to continue working. You know, through this whole time, I don't know if we mentioned this much earlier, but Sam continued to do whatever she could to work, even just being there. This was so important for her being. And we talked with her family and her loved ones, and creatively together worked out some type of a plan, a transportation plan. It involved a wheelchair, doing things where Sam had the option that if she wanted to be able to go to work that day, that she had the ability to do that. And knowing that if she went to surgery and had this prolonged stay within the healthcare institutions, this would really impact and impair that ability. Then third is Sam being with her partner and her husband. And again, if she proceeded with surgery, she saw that this was going to now be impaired, because being in the hospital followed by a rehab facility was going to make that something where she didn't have enough flexibility and control in this and what she was hoping for. So when we looked at our value-based goals, this then became quite clear to Sam what her next steps were that made sense to her. And that was not to proceed with surgery. We set her up to go home with a PCA, and she continued to meet and to talk with her oncologist about what other trials down the line might be options for her, because this was something that she really was, something that she wanted to pursue. So I hope by learning a bit about Sam and her story, this can help you to see that importance of palliative care being integrated upstream in cancer care, and really best brought in at the diagnosis of advanced cancer. And those, if you remember, those are what ASCO's recommendations are. I'd say some of the challenges that we face is that we're often brought in late into the trajectory. And it even sometimes is when patients getting closer to the end of their life. We know that there's a lot less that we're able to impact at this part. And when we can make the most impact and difference for folks is when we're brought in upstream. And there's so many opportunities to have that close collaboration and teamwork with oncology to be proactive with this patient so that we can have we can do work together towards improving that quality of life for our patients and improved outcomes. So some take-home points from today and around palliative care team. This is where we're focusing on improving quality of life for folks that are living with cancer. And it comes down to learning that patient story and bringing out from that the value-based goals of care and applying that to every part of their cancer care, whether it's their symptoms, whether it's when they have to make some really difficult and challenging decisions too. And the way that we can do this is when we are functioning as that interdisciplinary team, that hand, where we are working so closely together and optimizing that team approach to the patient's care. And then last is that communication and collaboration across the care continuum for this person that's living with cancer and being integrated into the cancer team. So I will open this up. First, see if there's any additional thoughts from our team members, and then also we would love to entertain questions, comments, and thoughts that you all have too.
Jeannie, I'm looking at the chat. I see a couple questions here at the end. The first from Carlin: how do you all take care of yourself and take care of others? Great question. I'll take the first crack at answering this. There's three very important parts of our day that we're incredibly intentional about as the palliative team here. The first is at the very beginning of the day, we check in with each other. There's a trauma stress continuum that we follow. You may have seen it floating around. It's the green, yellow, orange, red continuum. We check in at the beginning of every day as just a way to acknowledge, that we have lives outside of the hospital, and that sometimes those things impact how we show up in a day, so that we know how to be with each other in the middle of this. Knowing that somebody else is having a rough day is a really good thing whenever we're a hand together, right? The second thing that we do is the end of the day. It's called One Good Thing. It's an exercise in gratitude, where whoever is in the office, we get together and talk about the one good thing that we saw in that day. It may be working together a team. It may be something incredibly profound that a patient said. It may be that I saw somebody with a handlebar mustache that was incredibly impressive. It could be that I'm going home, but we all share one good thing. And then the final thing that we do is at the end of every consult, we do a debrief where we talk about what went well in that meeting, what could have gone better, how those things are impacting each other, and as just a way to kind of talk through what we just bore witness to. Those things are, I think, incredibly important parts of caring for ourselves, but also one another.
Yeah, I think those are our three tenets I feel like we practice with here really well. The thing that I often take away from my work here, and it's hard work, right? People do often ask, how do you do this day in, day out? For me, it's, being that bedside nurse back in the day, like watching the impact that palliative care and palliative medicine, the intervention has on patients and their outcomes, really makes me sleep well at night and see, like, man, we're doing well for this patient. We're really lifting up their voice in their middle of this tragedy, right?
What other questions do you guys have? It looks like Corey's question on getting a copy of these slides. We will be sending those on. So yes. What other curiosities have been tickled for you in the middle of this time?
Got a question for you all. First of all, just to thank you for being here and for sharing so much about your team. It's just a really beautiful example of what a robust team can do and the impact that you can have on people really throughout their diagnosis and treatment journey. And I love seeing that. My background, I'm a palliative social worker right now, and also worked in hospice and oncology before. I'm curious, especially, I'm sure that you still run into this as a challenge in the inpatient setting, but I'm wondering if you have any thoughts for the outpatient setting of how to better integrate palliative care early on in a cancer diagnosis. In my outpatient oncology experience, seemed almost like climbing a mountain sometimes to really be able to try to demonstrate the importance of that, how that can be supportive, how it's very different from hospice. That doesn't mean that you're dying right now, all of those things, and that it was also generally between two different providers. So, it wasn't someone who was already right there in the building. It's a referral to an outside provider, who is going to be collaborating in some way. So wanted to see if you have any thoughts about that.
Bonnie, I'd say that first, and I think you kind of mentioned on just the co-location. It's always, I think, works best when palliative care and oncology are co-located, with their clinics, because the communication that you can have is so much easier, especially when you're running into each other periodically. I think that really helps. And when the times that you don't have that luxury, I always say the key is around communication and relationship building, right? So keeping in close communication with folks, making sure that we're bringing in the oncologist voice throughout our interactions with the patients. I think oncology tends to develop the trust and that relationship when they know that we are expressing their voice in our conversations, as opposed to not checking in with them. And maybe then we can be causing more problems because we might be giving conflicting information. So as much of that communication as we can foster as possible in a way of how that oncologist prefers communication. And the third thing I would say, that whether you're co-located or not, if you have opportunities to do different kind of pilots or things where you are working together closely, that are bringing palliative care more upstream. So I think that kind of innovative work is something that a lot of cancer centers or a lot of oncologists are interested in, and especially when it's coming from some kind of a oncology society support. So I'll use ASCO as an example. So about maybe 2 years ago, ASCO, for instance, came out with their oncology medical home certification. And it's something that we've been collaborating with oncology for them to achieve that. And there are dedicated palliative care measures in that the oncology has to achieve in order to get the certification. So we worked oncology with the past 2 years. I would say that actually the hardest things to achieve were the palliative care measures. Definitely took the most effort and creative thinking. We are very fortunate that last month, the Anschutz Cancer Center did receive their ASCO certification. So it really can help that trust, that relationship building, and give additional opportunities to bring in palliative care upstream.
Go for it, Rebecca.
Hi. So I work as an occupational therapist and at an outpatient clinic that specializes with oncology rehab. And I've developed a program called ADAPT. And I work one-on-one with oncology patients, supporting their, whatever they need support with, really. Distress, side effect management, cognitive changes. And I bring the lens of occupation, which is that participation in what's meaningful to them, roles, activity, work, etc. And I feel like it's so a lot, like I'm a thumb. I'm in the thumb of the diagram. I feel like it's very much in alignment with the palliative approach of just helping folks manage some of the cognitive distress they have, the emotional upheaval, and just figuring out how to do their life in the context of now being a patient, where so many of our folks are healthy and in the middle of life when they get the diagnosis. But I do this work in the context of outpatient. And so that's another way I think that is supporting the population palliatively.
Rebecca, it sounds like it would be fantastic to have you as part of that interdisciplinary team. And the more disciplines that we have, that stronger the hand becomes. So it's always, I'd say, a luxury to even have more than one discipline for palliative care, because most teams may only have one or maybe two. And the more that we are able to bring in different disciplines, the stronger that we are and the better care that patients can receive. So I appreciate you telling a bit about your role, because it sounds extremely important.
Thank you.
I was going to add, that's really special work you do, and especially people like Sam that really benefit from it. Often, the PTOT teams are really focused on the healthy folks that are kind of improving and going to get back to those activities that they were able to do. And when we can't get back there, I think that's when your role is so helpful. So thanks for what you do.
And Rebecca, also a demonstration that you are a spiritual care generalist. Like the work that you're doing is incredibly important about them making meaning. Like a patient like Sam, it meant the world. It meant everything to her. And it was an important part of her spiritual care for her to be able to get in a car and get to work.
Well, I think it's 12:29, and I'm sure you all have patients, lunch, notes, in baskets, emails to take care of. So on behalf of the Colorado Cancer Coalition and the Survivorship and Palliative Care Task Force, we sincerely appreciate you taking time. We will most certainly share this presentation with everyone because it's so very, very important. And as we, look forward to the future, we hope to continue our collaboration with you all. So thank you so much for sharing